directors, Colm Byrne and Suzanne Marshall from Good Shape, who are going to talk about planning, workforce planning, and the workforce around about mental health. So interestingly, it's a couple of areas that have been referred to before. Staff wellbeing, particularly across the pandemic, and from Pat's presentation there around about how do we encourage, in terms of a work-life balance, people to be interested in the jobs of the future. So good policy around about staff wellbeing is going to be key to that. So I'll hand over to Colm and Suzanne to talk about the work that Good Shape have been doing in this area.
Suzanne and I will just introduce ourselves very quickly before we start. Suzanne, do you want to go first?
Yes, so I'm Head of Clinical Strategy for Good Shape, and my background, I'm an occupational health specialist practitioner.
Okay, I'm a freelance HR consultant, and I've been working with Good Shape as a consultant since September last year. I've had a long history in health and social care. I'm a mental health nurse by background. I've been a registered mental health nurse since 1981, so 40 odd years now. But more latterly, I've worked as the Deputy Director of HR in a large acute NHS trust. So Suzanne and I are going to take you through a number of slides. So our focus this morning is on mental health as an issue causing significant absence, particularly in the NHS, but across all sectors and all employers. So we're going to give you a number of statistics. We're not going to really talk too much to these because they're easily accessible. The data that we're presenting you with is Good Shape data. We collect data from NHS trusts in particular that we engage with, where we have over 40,000 NHS employees on our database. So these figures are taken from that source, but much of this is accessible, as you know, from .gov.uk data. But mental health is the #1 reason across virtually all sectors, especially including health and life sciences. When I last worked in the NHS, the employer I was with, our absence rates for mental health absence was 30% of all absence. So it's quite significant. Suzanne, do you want to say any more, or should we move to next slide?
Next slide, please. Thank you. So within the NHS, the amount of working time lost to poor mental health has been virtually equal to that for confirmed cases of COVID-19. And of course, we need to look into the resource due to the burnout of our clinical staff.
So looking at the average duration of mental health absence and comparing it with the average duration of absence for COVID-related issues, you can see that there's a significant difference. Mental health absence accounts for 3 times more absence due to COVID. Now, that was as of June 21. We do know that the Omicron variant caused a spike in absences, and in some trusts this increased by, I think, 38% were the figures I looked at recently, because of the Omicron variant. But fortunately, that looks as though it has now peaked and has started to come down. And whilst that was the case and COVID absence peaked, there was also a significant increase in mental health lost days of around 10%. So the two do seem to have a continual relationship.
So 1 in 12 people will actually need time off work for COVID-related reasons, will then go off and take time for poor mental health. And we know that mental health absence actually lasts 63% longer than a COVID absence. And I think you need to make sure you talk to employees who are suffering with COVID about looking after their mental health at the earliest possible opportunity at the early.
So one of the other interesting pieces of data that Good Shape has identified is that when employees go off work with a mental health related absence, so that usually would be stress, anxiety or depression, our data seems to suggest that that happens twice. And then if there's a third episode, the employee doesn't return to work. So it's a bit like 3 strikes and you're out. As an employer, you're given 2 opportunities, I guess, to get it right with your staff, to support them and get them back to work functioning properly. But if there is a third episode, the evidence is that 54% of employees will leave. Now, in a climate at the moment with a skill shortage and high vacancy rates, there are few employees, if any, that can afford that sort of loss of skills and people.
So we've just heard some interesting details from Pat, and we know that we're going to have the ICSs in the short future. And what we're going to do here is we're going to join the NHS with local government. But interestingly, from our data, we've actually seen an even bigger mental health problem within local government. This sector has actually seen 68% more mental health related absences than the NHS since 2019.
So looking forward to what is about to or is already in place as a workforce pressure in the NHS. So clearly we've got the Omicron variant, and fortunately that now seems to have peaked and is coming down, although there are still a significant number of patients with the Omicron variant in hospital at the moment, and that will clearly take some time to subside. Those of us who've worked in the NHS will be very familiar with our winter planning and the winter flu season and all the joys that brings. So apart from getting our act together and getting a good flu vaccination program up and running, every winter, as HR colleagues will know and clinical colleagues will know, seems to become longer and longer. In fact, most of you will probably identify, as I do, with the view that there was no longer a winter peak, that in fact the pressures have become all year round. And some of the reason for that is that when people are coming into hospital now and are more elderly and more frail, and with a range of complex cases and conditions, the ability to discharge them back into their own homes is becoming significantly affected by what can only be described as a crisis in social care. So the winter flu season becomes an all year round issue. With COVID now, the likelihood is that we will have to have a booster vaccination program to include COVID as well as flu on a regular basis. And that is an unanticipated pressure that will now have to be factored into workforce planning for the next few years. You will all know that there's a backlog of elective care. The recent estimates I've heard is that 5 million people are waiting for elective surgery, and that's an enormous burden, which is clearly not going to go away anytime soon. The advent of the ICSs is an interesting one. I was about to say to you this morning that we know that was in line for April of 2022, although I had some doubts because I had heard that the legislation was delayed. Patricia has just confirmed for us that the Health and Care Bill is still a bill, not yet an act, still going through Parliament. The chances of it becoming statute by April, in my experience, now look remote. But when ICS does become statute, those of you in HR will know, as I do, the significance of that for us, because whether we like it or not, there'll be significant review and restructure of existing services. And that will include a lot of TUPE transfers, I would imagine. Patricia told us that there's a 5-way merger going on between various NHS England bodies, which again, from a HR perspective, adds a level of complexity that we hadn't necessarily anticipated. The funding and staffing challenges, or funding challenges, are ever constant. I just wanted to say a few words about the VCOD, the vaccination as a condition of deployment for healthcare workers. I don't know if you saw PM questions yesterday, but the Prime Minister was very, very robust in his views, and he had a number of front and backbench MPs saying, will you please delay this? And he said, no, he's absolutely of the view that healthcare professionals ought to be vaccinated. There are various estimates of the impact this will have on the workforce. And the estimates I've seen vary between 52,000 and 70,000 NHS staff being unable to be deployed as a result of compulsory vaccination. And if you want more information on that, I've seen data produced by the Royal College of Nursing. And in fact, there was a panorama programme looking at this issue just the other day. So that is going to be a challenge, and how we manage that locally is going to be very difficult. I know a lot of HR colleagues that have put out advice to say, well, if you're a clinician and you don't want to be vaccinated and don't have a medical exemption, then we will try to deploy you to an area where you don't have direct patient care. I mean, colleagues, you must all realize that that is very, very, very difficult in the current situation that we're in. To deploy clinicians to non-clinical roles is going to be very challenging.
So hopefully that's given you a flavour of the data that's been produced by ourselves to match with the government data. So that highlighted the problem. What we want to do now is actually try and talk to you about how we can implement some change and possible solutions and support you out there with your workforce planning. So using technology to get good data is absolutely key. It's the evidence you need to make your informed decisions. We don't want to keep doing what we've always done, and we certainly don't want to be guessing. So our data is there to identify and predict hotspots where our mental health is actually starting. We want to identify the root causes for a targeted response. We want to combine the data that we've just shared with you with other sources so that you're looking at a holistic national view to get the bigger picture. Make informed decisions for an efficient workforce planning, and plan your mental health wellbeing strategy, which includes a lot of training, not just for your line managers, but your employees as well, to actually recognise if they're suffering with mental health issues themselves. We need to understand who's actually absent, why they're absent, and when they're likely to return to work. We want to make better decisions for more efficient workplace planning, and we want better interdepartmental connections so that we can share best practice. We want more efficient cost cover, block booking as opposed to day by day, and that could help us minimise costs of our administration.
Okay, thanks, Suzanne. So having good data is key, and one of the challenges I faced in the NHS was that I didn't always trust the data, in particular ESR. And even if the ESR was good and I trusted the data, I actually found a richness in data which was much closer to the source. So in fact, it will be your staff who tell you the areas where there are problems and mental health hotspots. So you will all know within your own organisations which departments throw up more grievances, more disciplinaries, more disaffected individuals, complaints, etc. And when you look at your absence rates, you will almost certainly find that they mirror each other. And a piece of work I did a couple of years ago looking at grievances in a large NHS acute trust showed me that they were arising in areas where there was a high level of staff who were in the lower paid bands, and that they were in the least professionalised areas, such as estates, hotel services, those sorts of areas. And that should allow you as a HR department to target where you put the majority of your prevention resources. So you consult at individual and demographic levels, but you also need to use your individual appointments, your return to work interviews, to really get to the heart of what is going on with somebody's absence, and not just rely on your policies and procedures that will bring you some sort of resolution. The other thing I would say is that once you've identified a particular theme through your data, as we did with, say, our lower banded staff, we then look to preventative measures. You know, it's a bit of a cliche, but prevention is better than cure. So again, you know, without patronizing anyone, you will all know that it's very useful to have trained mental health first aiders on the ground so that they can at least signpost staff to the sources of support. So if you've got an employee assistance program, for example, one of the things that we know is that there's a very poor take-up rate of EAPs. And again, just in relation to Good Shape and the organizations that Good Shape works with, we provide an employee assistance process that is accessed by 70% of the staff who need to access it, whereas in the NHS, it varies between 6 and 10% of take-up of EAPs. But it's about really getting close to your staff, and as I said in the previous slide, finding out exactly what is going on. I'll give you an example of a case that we had where we had a woman who was frequently absent for short periods, and then went off with stress. And in the return, not the welfare interviews rather, what she disclosed to us was actually her stress, anxiety, and depression were being caused by a violent partner. And she seemed to indicate that there was virtually nothing we could do to get her back to work because the ex-partner knew where she worked and he knew her shift pattern, and he would wait at the bus stop when she got off the bus to come into work. So she couldn't come into work because she was frightened. So we had to make a response to that fitted with her circumstances. And for a 3 or 4 week period, we had a member of our security staff meet her at the bus stop and escort her into work. And that worked really well until the ex-partner got the message and then went away. And now that's not obviously a one-size-fits-all. We couldn't do that in all of those types of cases, but it does sometimes mean that you need to think out of the box. You might need to move people from one department to another, where maybe they've had some, you know, they may have had previous problems in their own department with personalities and so on. I would say that we need to reassess our absence policies to make them fit for each and every particular purpose. Only insofar as, you know, we have in HR policies, we have some structures where we say, well, 4 weeks is defined as long-term absence. Why? Why 4 weeks? If we know it's a recurring stress and depression problem, why would we wait 4 weeks to, you know, maybe get somebody in, refer them to OC Health or for counselling or to an EAP or whatever? So, you know, let's be flexible. Let's keep in touch with our employees, get alongside them, and make sure that the support we offer is tailor-made for them as individuals.
Oh, if I could just add to that, Colin. So what I really just wanted to say was, I saw a note just now on the chat line just saying mental health is a much bigger picture, and there's different types of mental health. And at Good Shape, we've actually developed 3 different return to work forms, because previously I'm very aware that most organisations have one return to work form that fits everybody's conditions. And I've always felt that, you know, to have the most effective meeting, which, I mean, return to work is a really important toolkit, part of your toolkit for managing mental health. And so we developed 3 different ones, and one is for bereavement, One is for stress and anxiety, and one is for the other one is for diagnosed mental health conditions. And we found by separating these out, we're actually really understanding the true root cause, rather than just saying, you know, mental health is just one topic. Yeah, I just wanted to reiterate that part. Thank you.
So again, this is back on a similar theme, really, which is around making whatever support service you have visible and easily accessible. And the easier that you can make it to access, then clearly the more take up you're likely to get. However, it is pointless referring somebody to occupational health if they're suffering from workplace stress or any other form of stress, if there's a 5-week waiting list for an appointment. And all too often that has been the case. And during the pandemic, clearly the pressures upon occupational health colleagues has been exacerbated. So minimizing delays is essential. And you know, you might want to think again on the basis of reviewing policies and procedures. If somebody identifies a mental health issue as the reason for their absence, that almost should automatically trigger a referral to your support services. So it would trigger them being provided with information about an EAP and about being referred to occupational health for an appointment. Some work I know by NHS England looking at responses to absence rates indicated that those employers who outsource their occupational health provision had a lower absence rate and a higher take-up of occupational health services. And obviously, you know, Good Shape provides that service. My main point around signposting and referring to support services, I think, is really about having a joined up approach. Is about having a joined up approach. So what works for one individual won't work for another. And at the start of the pandemic, one of the things that we had in my acute trust was we had a significant number of volunteers came forward to help during the pandemic. Amongst those were some trained psychotherapists and counsellors who offered their services free of charge to the NHS for frontline staff. And so that was really useful, and we took that up, we took that offer up. Sorry, Susanna, did you want to add anything to the previous slide?
Yes, sorry, on the previous slide, my main point that I wanted to make is that we want seamless referrals backwards and forwards from our wellbeing partners. And I think it's really important to have view and sight of our wellbeing partners. So, you know, may I suggest that you have a wellbeing event day where you actually ask someone from your occupational health team, your EAP team, perhaps your fast track physio, have them all together in a big group where your staff can have access to them and speak to them long before they actually need the referral, because I think it improves confidence and understanding, you know, in case they ever do need them and need their help. Thanks, Con.
Okay, so the next slide, you'd be pleased to know, is the final slide. But this is aimed really at those of you who are in the HR function or manager function where you have responsibility for oversight of staff and to intervene on, particularly on absence rates for a variety of reasons. So we talked about the benefits of good data and what that can bring you. We talked about the benefits of using the data, but alongside that, getting close to staff and staff side organizations, such as trade unions, who have an enormous amount of insight into what's happening on the ground. And some of the professional associations also have their own support services and counselling services. Particularly, I'm thinking of the RCN and the BMA have their own access to good support services. But of course, as we've said already, not everybody, the effect of the pandemic on everybody is not the same. Some people are more affected by it than others. But the NHS had a 30% absence rate for mental health before the pandemic started. So this is a long-term issue, not a short-term issues. And you know, we certainly do appreciate that HR managers and others are under pressure. But I thought it'd be useful for you to think about what is it that clinicians in particular are saying is causing them stress and causing absence. So I did a webinar a couple of days ago with the Nursing and Midwifery Council, and they've identified 5 key things that are stressing registered nurses at the moment. First amongst those is the enormous sense of responsibility that they feel for others. And particularly when you've got a pandemic that has now caused over 150,000 deaths, you do appreciate that our doctors, nurses, and allied health professionals, you know, let's not forget our ODPs, our theatre staff, our radiographers, our physios, etc. They're all witnessing scales of distress and death that they probably haven't seen before. So, you know, that sense of responsibility, being a decision maker when people's lives are at stake, weighs very heavily on people, not just whilst they're at work, but also, and probably especially, after work. The second thing that they said was really stressing them out was that they were crossing red lines all the time. And that they were doing things this year and last year that they had never done before, that would have been unthinkable, that were outside their normal standard operating procedures and policies because of the context of the pandemic. The third thing they said to the NMC was their fear of making wrong decisions. And what the NMC is trying to do is to say to nurses, registered nurses, providing you record what you do and you keep a rationale, you can give a rationale for what you do, and clearly you're acting in the best interests of the patient, then they will take that context into account. The fourth thing they said was accountability, and then the consequences of accountability. So of course, yes, as professionals, we are all accountable, but if you feel that your organization will punish you for making wrong decisions, then that really ups the professional risk to you and makes you feel psychologically unsafe in the workplace, which again, we know is a key indicator for mental health absence. So one of the things I would say to all of our colleagues, HR and manager colleagues, is work closely with your staff, find out what is going on for them. And I think really thinking back to what we can do on whole systems for supporting mental health is to relook at the Dido-Harding guidance that was issued in 2019. You remember the letter to all chief execs, learning lessons to improve people practices, which followed a very tragic case in London. That talked about practicing a just learning culture. So avoiding suspensions if at all possible, avoiding disciplinaries if at all possible. And again, that goes back to getting alongside people, finding out what went on. And unless there are examples of willfulness or extreme cases of neglect, the majority of cases can be understood and responded to. Doesn't mean that we don't hold staff accountable, of course we do. But in the context of a just and learning culture, we can learn from their mistakes and our own mistakes as systems. The other thing,
just mindful, Colin, just mindful of the time for our colleagues here with their 25 minutes.
Right. The final thing I will say then is the NMC have expressed to managers that practice the duty of candour and explain to staff if things are going wrong, why they're going wrong, and what measures they're going to put in place to support them in future. Sorry, I've rambled on a bit.
I had some things to add to this slide, but I think we're just very close to our time. So. Thanks, everybody.
Okay. Thanks very much to Colm and Suzanne for their presentation. There's been some interesting comments in terms of the chat functions around about some of the things that you're touching in terms of PTSD and categorisation, broad categorisation of mental health.